Move forward.
Yes, we did.
All right. That's in the past tense. It's in the past. Now we look forward to whatever. Monday? Anything Monday? Okay. But that's still written and then the hands-on, right? Those ones I like, because if you've actually been spending time practicing, at least what you've been practicing in lab is going to go along with what the questions are going to be on the desk, because you've been practicing it in lab. So, okay, so funk skills on Monday, and then Friday, psych. Okay. And then me. 3 left? Ooh, nice. Yeah, a lot of it in the paper. Yeah. Hopefully you've already done some of that. No? That's okay. So to be honest, when I came through, it was like a 20 to 30 page lit review, and way different than what you guys are doing now, right? Way different. And so was that. So I did it all on the break. So like the semester break, that was when I did all my research and all my writing. It was weird. It was always due like week 4 of this semester. The next stage is due, and I'm like, well, I guess I'll do it on the break. But yeah, we had to do like a 20 to 30 page. You know, you guys are like looking at the articles, right, and doing all that. We had to do all that and then just regurgitate what the article said and explain all the p-values and all the important stuff of like all these different studies without actually. It was kind of answering the question, but it was more, do you know how to read this stuff and interpret it? And so I like it better now, where it's at least somewhat valuable to what you're going to be doing in clinic. Anyways, now that the eyes are behind you, any questions about yesterday's stuff? Okay, we are going to finish the chest today. We will start a little bit of abdomen. So we'll run through it. COPD. COPD is our next thing we're going to talk about. All right, what is it? It's progressive chronic airflow obstruction. All right, you're going to learn this more in pulm, but COPD and asthma look the same symptom-wise. They're going to look the same pulmonary function test-wise, PFT-wise. The difference between COPD and asthma, from a foundational standpoint, is when you give them the inhaler and you do those pulmonary function tests again, did they get better? If they got better, it's reversible, it's asthma. If they don't get better, it's not reversible, it's COPD. You'll learn that more in pulm. For us, chronic bronchitis and emphysema are going to be the two that we're going to lump together in COPD, right? I care about COPD as a whole in this course because on X-ray, it's going to look very similar, okay? So your blue bloaters, your pink puffers, that's the descriptor term for kind of how the patient looks that you will get in pulm, the distinction between the two. Your symptoms are going to be dyspnea at rest or dyspnea on exertion. Great, I have dyspnea, right? Fantastic. Chronic cough with or without sputum production. Wheezing, all the things that we talked about already. All right, could be a dry cough, may not be. But it's going to be chronic, right? This isn't I've had a cough for 7 days. I've had a cough for 2 weeks. This is the person who's been coughing for months. Had a chronic cough for years, and they're just coming in because it's getting a little bit worse, right? This is not an illness, acute type thing. COPD is a longevity thing. What are you going to see on imaging? You're going to see lung hyperinflation. We're going to see what that looks like. Diaphragm flattening. We're going to see what that looks like. Now we've seen the normals. You guys will be able to kind of start to pull that stuff out. The distal pulmonary vessel tapering, maybe really those top two are what you're going to really focus on the most. And in the chronic bronchitis ones, you may see some increased lung markings down at the base. But your top two, your lung hyperinflation, your diaphragm flattening is what's going to stand out. Much like our tension pneumothorax, right? There's different ways to actually diagnose this stuff. So your chronic bronchitis is clinically defined by a productive cough for more than 3 months in each of 2 successive years, and you've excluded everything else. You gotta have this, rule out all the other possibilities, and you can say it's chronic bronchitis. Because a lot of your bronchitis are acute, right? It's inflammation of the bronchi. Lots of things can cause an acute bronchitis. So if you're going to call something chronic, you better make sure that it's actually chronic, not being caused by something else, and then you meet those minimum standards that they've had over at least a 3-month consecutive period of chronic cough for 2 consecutive years. Right, so that means it could have been going on for 4 months and then they got better. And then the next year it's going on for 4 months and they get better. Okay, boom, I got enough. If I got 6 months 1 year, but I haven't hit 3 months in the next year, I don't have enough clinically to call it chronic bronchitis yet. Because I haven't had the cough yet in that 2nd year. Emphysema is going to be pathological, okay? So what you're going to see is permanent and abnormal enlargement of the airspace to the terminal bronchioles. There's not really like a clinical thing of emphysema. It's going to be more pathological. But really, again, what I'm focusing mostly on here in this course is your chest x-ray findings. Hyperinflation and flattening of the diaphragm, especially on the lateral. This is one where we look at the PA, sometimes we see flattening of the diaphragm, we're like, yeah, maybe, what's going on? Is that a supine pneumothorax? We talked about it a little bit, right? But really the lateral is where it's going to show you. Other things you often see, you see a larger retrosternal clear space. So we saw that darkened space behind the sternum. Well, if my lungs are hyperinflated, that means there's more air in them, right? So you're not pushing the air out. So some of those darker areas, like behind the sternum, are going to be even more darker because there's more air, right? Because the air is not getting pushed out. Hyperlucency of the lungs with decreased vascular markings. Again, why do I have decreased vascular markings? Because I can't see them as well because I have more air. So the air is kind of going through it. They're not compressing down. We'll see what that looks like on x-ray. Again, the pulmonary arteries, maybe. But if you focus on the other things, you'll be able to pull this out. CT findings is there. If you get the CT, you can use the CT to evaluate how bad the disease is. But really, you're only doing that like for surgical procedures. This is not going to be a standard process for COPD, and x-ray is going to be enough to take a look at it. Here's my normal. Here's my abnormal. Yes, probably underexposed. Now here's the tricky part with this. Is it truly underexposed? Or is it just, it looks like it's underexposed, but could you imagine if I increased, look at how dark the lungs are here. So I have lungs that look like they're overexposed because I can't see the vasculature. I got a spine that looks like it's underexposed because I can't really make out the vertebrae. What is going on here, right? This is the nature of some of these disease processes. If I increase, or the tech increases the radiation to make sure you can see the spine vertebrae, these lungs are going to be even darker than they already are. So there's this give and take sometimes, depending on what the condition is. They're going to get you what they can, right, to try to better evaluate. Because if they increase that, all of these lungs are going to turn super black. And then you're like, well, now it's overexposed. Well, no, it depends on what you're trying to look for. And that's where your history really comes into play, right? Because if I, as a rad tech, take this picture and I know it's a patient with concerns for COPD, I'm going to call that good. Because I know if I increase that, I'm going to kill the lungs. You guys aren't going to be able to see what you need to see, all right? So a couple of things we have on here. The biggest thing, we're going to have some of these blebs. So you see these kind of like radio opaque lines, but they're forming these like larger kind of air bubbles is the way for me to describe it. Here's the wall of your bleb. These are your air bubbles. On this side here. And that's why we're not seeing those lung markings. We kind of saw that briefly when we were looking at the pneumothorax. I have no lung markings, but I have that kind of radio opaque line that doesn't match up the thorax, and I still can't see them. It's because of how expanded, okay, these alveoli are in these areas of air. It's not pushing it out. It's losing its elasticity, so the air just kind of sits in there. So that's what the blebs are going to be. You find some other ones that aren't as burned out. Okay. This one I like for my my flattening of my diaphragm. We'll get to the hyperinflation in a second. But look at my lateral. Look at how flat my diaphragm is on the lateral. When I found my normals, right, we had the little hump. There's a hump here. But now it's nice and it's flat. So that's clue number one. Okay. Is this a large pleural effusion? I don't know. Let me look at my PA. No, definitely not. Right? Because if I was completely flat, I would expect to see some significant blunting of my costophrenic angles here. And maybe a little bit, but it's definitely not significant. So I have a flattened diaphragm, and then look at how much darker my retrosternal space is compared to some of the normal lateral x-rays we look at. I don't have any lung markings here at all, and this white arrow is the flattening of the diaphragm. Okay. What the white arrows in the center one are showing you is supposed to be that tapering of the pulmonary vasculature, right? Again, that's an advanced read. It's an advanced finding. When you start seeing more of these, that may stand out to you guys. If I'm giving you a COPD X-ray or a COPD patient, they're going to have the extra dark radiolucency of the retrosternal space, the flattened diaphragm, okay? Maybe a bunch of these blebs and stuff like that there, along with that. I'm not going to give you just the tapering of the pulmonary vasculature and say pull out that this is a COPD patient. That's an advanced read, but it is technically a finding on the film that helps you think about COPD. All right. So this is what we're talking about down here, though, the hyperlucency of the lungs down here, right? We talked about how the lungs are supposed to get darker as they go up, not get darker as they go down. Okay? So when I compare this area of the lungs with the rest of the area, look at all my vasculature up here. I can see my vasculature quite well. Or if I just want to do the side-to-side view with my normal, I can see my vasculature and all my vessels here on my normal. But then when I shift over my COPD patient, right, I have these darker areas. There's also something kind of going on, what we call this is barrel-chested. Right? When I look at my lungs, my thorax, it almost looks like a barrel. And part of that is because of the flattened diaphragm. But then the hyperinflation of the lungs makes them much longer than we've seen on a lot of our normal x-rays. So those are all kind of clues for these patients to go along with the symptoms that COPD might be something that's in your differential. Okay? Yes, sir. So are we looking at kind of right here? Yeah, so with COPD specifically, you shouldn't see necessarily spine sign because of the fact that we're more hyperinflated. So if anything, they're going to get even more darker down here. And remember, spine sign is when they don't get darker. So what's going on here? I don't know exactly what's going on there. So this is what he's kind of looking at here, right? Just in this area. But spine sign and COPD typically do not go together. Right. So now here is a PA and a lateral of a COPD patient. There is no normal on this film or on this slide, okay? So again, what we're looking at is look at how much more radiolucent these lungs are compared to the normals you've seen. I can barely see any of the vasculature. These lungs are hyperinflated. It's actually exposed pretty well. I can see my thoracic vertebrae fairly well on here. But these lungs are very hyperinflated and much darker than we've been seeing. And then here's another one on the same concept. Look at my hyperinflation. Look at how long the lungs are, right? It's that barrel-chested kind of look and view. And a lot of times on the really older patients that have really bad COPD, you actually will have to get 2 chest x-rays because their lungs get so long that on one film, it clips these claustrophrenic angles, so they have to actually do an upper chest and a lower chest. You won't have to worry about that. It's not an order you're going to do. But on the really sick patients that have had COPD for a really long time, they have these lungs that are just massive because of the hyperinflation. That's the extent of what I need you to know on COPD. Flattening of the diaphragm, hyperinflation, the patient's symptoms. Okay? That's the extent of what I need you to be able to pull out. Say again?
For a flattened diaphragm, is that only on the lateral?
Yeah, so you use the lateral to view the flattened diaphragm. And the reason for that is it's really hard to see a flattened diaphragm on the PA because of all the other stuff with like the liver pushing up and the spleen and the stomach. And it's just not well diagnosed on a PA. So that flattening of the diaphragm is best seen on the lateral. Okay? And if you go back, and I didn't put one in here, maybe I should do that for next time. If you go back and you look at our normal lateral chest x-rays, they always have those 2 pieces of the diaphragm, the right and the left, and they got this nice hill kind of hump formation on all of my normal laterals. But my COPD guys and gals are going to be flat. And it's because the hyperinflation of the lung is pushing down on that a little bit, kind of flattening it out because the lungs are so hyperinflated. Yeah, good question. Okay. Foreign bodies, blebs, bullies, cysts, cavities. Oh, yes, sir, sorry.
Sir, could you go back to the COPD?
Absolutely.
Why are the lung markings appear more radio opaque than like the heart on the left picture?
Here?
Yes, sir.
There is no heart.
That was my way of asking that.
Yeah, right? There is no heart on this patient. This is me, if you ask my kids, and they complain about stuff at school. Right here. You guys can complain a little bit. No, so there is no heart on this patient. I don't know why. And I get that question every semester. I don't know the history behind why there wasn't one, and I'll be honest. When I pulled it up for COPD stuff, I was like, perfect. And the first time I threw it up there, I completely, because I was so excited that it was a good, like, barrel-chested x-ray, right, that systematic possibly telling you guys to do. I didn't do it. I was like, this is a perfect barrel-chested x-ray. I threw it up there, and it was somebody in class like, hey, where's the heart? I'm like, what are you talking? Oh. So there isn't one on here. I don't know if this is a post-mortem one or not, which is very possible that it could be a post-mortem, maybe after an organ donation or something like that. I don't have that answer for you. But yes, there is no heart. So good, you did your systematic process. And you did become the first class to not point it out since I put it up there, so that's good. Now let's go to this. All right, what are those? Pearls. Sweet. We'll make some money once I get them out. Anybody have any idea? First of all, do you think this is an adult or a pediatric? All right, look at the spine. They're not kidney stones. They're bright white, so they're probably metal in some way. These are magnets. These are magnets. This kiddo swallowed magnets. Right? This is a problem. This needs surgery. Because the danger of this is multiple magnets. The danger of this is if they separate in the intestines and then one comes down to a different loop and I break the clicker and then they connect in two different loops, they can connect on that and they can actually cause the bowel to start to die because it cuts off the blood flow and it causes a constriction. So if you end up seeing something like this, and I can't swallow something, I want to look, and you get the x-ray, this is something that needs to get seen and is likely going to need surgery to get them removed. Still work? Let's see. Ah, yes. Okay. So yeah, so these are magnets. These are concerning. You'll learn more about that in PEDS of what exactly to do for that. Just let it pass is not the answer. If it's one magnet, just one, then sure, we can probably let that pass. But if there's multiple, we need to get them out there. What do we got here? Coins. Coins. Right? I wouldn't even say this is a kid. So I don't know what the heck this person is doing. But normally it's kids that are swallowing these things, right? Are these coins, where are these coins at? Can we tell where they're at? What part of the anatomy? I heard bronchial tree, right? Looks like I got one on the right and the left potentially. Here's my lateral. Here's how you can tell. I don't need you to know that for this test, but this is going to be good for clinic. This is how you can tell. Right after I told you it looks like the bronchial tree, I'm not really sure. I then show you this one. Know this so you know where they're at, because if they're in the trachea, I need to get them out. If they're in the esophagus, they'll probably just pass right through, no big deal. Most coins. You're not going to go do surgery to get coins out. But this is a good way for you to kind of tell it, and it's just kind of how the coin sits in the body parts of why it looks this way. So, there you go. Use your lateral and your PA to figure out which one is likely which. Now, if they're small coins, right, use your common sense, right? If they're small coins, is it possible that they start off this way in the trachea, and then when they get to the bronchi, they shift because the bronchi are a little bit bigger, and they're smaller coins? Sure. If they're having difficulty breathing, then suspect that. But again, just know that they're foreign bodies. They're not supposed to be there. Okay? I'm not going to make you pick between esophagus and trachea, but this will be good for you in clinic. Okay. Normal airway. Why does this matter? Simple answer. We don't know what normal is. We can't find the abnormalities, right? Just a reminder of what the normal anatomy of the airway is. That's a trachea, not an esophagus on an X-ray. Okay. So, why did I show you those foreign bodies? Because foreign bodies can cause obstructive atelectasis. Okay? Yes, this is rotated. For those who are already asking in their heads, yes, this is rotated. You can see it up in here. I agree with that, right? Which is why we have more of the right side of the heart over on the left side, so the heart is not necessarily the abnormal concern. Okay? Slightly rotated. But what I do have is an atelectasis sitting right up here. Okay? Starting to pull my trachea over a little bit. The rotation does a little bit, the rotation doesn't do this much, and I have the atelectasis. But obstructive atelectasis can be caused by foreign bodies. There you go, foreign bodies. Know that it can cause obstructive atelectasis. That's what you're concerned about. Okay. RADS Block cyst cavities. Let's break these things down. Bleb and bullae are the same thing. It's an air pocket. It's a filled, usually circular air pocket in the lungs. Blebs are small, less than a centimeter. Bullae are bigger than a centimeter. What's 1 centimeter? Take your pick. Right? Probably bullae. A bullae is just a larger bleb. Most blebs you can't see on X-ray because they're so small. So if you can see it on an X-ray, probably a bullae. I would lean towards bullae. I would call it a bullae. Or if it's a non-pictured question and it has a size in it, read the size. We're going to look at blebs and bullaes. Primarily blebs are going to be CT images because that's where you really see them really well, and you'll see how small they are and why they're so hard to see on X-ray. And why they're important. Cysts. All right. So cysts and cavities. Cysts have a thin wall. Cavities have the thick wall. We already saw some cavities in that cavitary pneumonia. Okay. How big are the walls? 3 millimeters versus less than 3 millimeters. Right? So your cyst is between 1 and 3 is what that's saying. Millimeters in size. You really don't necessarily you'll be able to see it on X-ray if it's a thick one or a thin one, but these sizes will be important because the radiologist will measure them, that kind of thing. If you have a cavity, usually we're concerned about a necrosis portion of the lesion or TB. What do their always look like? Okay, that white arrow is your bleb. That little itty bitty circle right up here. A lot of times they're in the apex. Not all the time, but most of the time. Less than a centimeter, you are not going to see that bleb on X-ray. So this is the same patient. This is a scalp film. So when you go for a CT, what they do is they basically first get a generalized X-ray of the area they're scanning, and then they use like this highlighted box based off of this scalp film to say, hey, I want you to scan the CT, the actual CT from like here to here, from here to here. And that's what tells the scanner what to scan. So it's kind of like an X-ray, but they're lying down because they're on a CT scanner, right? So when I show you this, where's the bleb? Like you can't see it, but on CT, I absolutely can. So it's very hard to see on an X-ray. So if you see one of these circular air pockets and you see them on an X-ray, just lean right towards bullae. Okay? Why is this important? Well, these are important because what's happening near this bleb on the CT? Right? What's this guy here? That's a pneumothorax. I have air between my visceral pleura and my parietal pleura. Often these blebs are what lead to those spontaneous pneumothoraxes. or thoraces. So that's why this is important, because when I have the bleb, I'm now at more of a risk of having a spontaneous pneumo, which also means, like, that's not a whole lot of air, right? So obviously we had a couple that already burst on this image. So if I just have one or two little blebs and it gives me a spontaneous pneumo, that's why if they're not symptomatic, all these things, they'll just heal on their own. The body will adjust, that will heal, the air will go away. You just got to kind of keep an eye on the patient and give them return precautions. But blebs can lead to spontaneous pneumos. Bullae are much bigger. Still thin walled. They're both thin walled, right? The cyst and the cavity is the difference. But for blebs and bullaes, they're both thin walled, and they can get massive. This is not a pneumothorax. It looks like a pneumothorax, but look at my radio-opaque line. That is not in line with the shape of the thorax wall. That is your distinguishing factor when you're trying to figure out, is this a bullae or is this a pneumo? Can it lead to a pneumo? Sure it can. But when it bursts, that radio-opaque wall goes away because it's no longer this round bullae that's sitting there, and then you end up seeing your pneumothorax. Here's what they look like on CT when you have a bunch of them. So you have a bunch of bullae. These are much bigger than 1 centimeter. Okay? Your larger blebs are a lot easier, your larger bullae are a lot easier to see on x-ray. The concern with that is this is when we start having issues with oxygenation. The bullae do not allow the transfer of oxygen to the blood in the alveoli. They are too big. It doesn't allow it. Yeah, what's up?
Is the bullae like a trap pocket of air thin walled, or is it what's inside of the bullae?
Air. It's all air. Yeah. Yep. So think you're really bad like emphysema and COPD patients, right? They lose the elasticity to those alveolar sacs and alveolar wall. So when they lose that elasticity, it can't push all of that carbon dioxide and air and stuff like that out, so it doesn't squeeze back down. And then you breathe in, they get a little bit bigger, and it doesn't squeeze all the way back down. And then you breathe in, they get a little bit bigger, and this happens over time, for months, over years, and then eventually they just continue to get bigger. And that's why there's a lack of air exchange, because there's not really much air in, like oxygen that's going in there anymore for the blood to take over, because it's the carbon dioxide exchange that's not getting blown out because of the lack of elasticity. Go ahead.
It's a small air pocket full of the that's
That one there? Yeah, it's probably just another one of these guys, it's just not as big. Yep.
How does it get that big if it's just like a sack? Alveolar sac.
It just continues to keep getting bigger and bigger, or you have a bunch of these and this will just get bigger. And eventually, like when one of these guys starts getting really big, it's going to make the other one smaller and just kind of push it out of the way. It's just all going to be based off of, it depends, right? The pressure of one versus the other, how long they've had it for, is it going to keep getting bigger? And so it's variable. Yeah. They're there, but you can't really see them because, like, the lung is still there. To determine what? It's not important. It's not important honestly, as far as the lateral to know, because really when you do the lateral right on this patient, I'm just going to see a bunch of lung because remember they're superimposed on one another. Right? It might be a little bit darker because I have more air in the bullae here, but really if they're just superimposed, so I'll end up seeing lung markings and everything from the less affected lung, we'll say. Right? So it doesn't really matter which way it's pushing the lung tissue or anything like that right now, because we're just more concerned that they have this giant bullae. And it decreases your oxygen transfer and absorption, which is what leads you to be hypoxic, which is why what do we see this in smoking patients a lot of the times, because they're the ones that are developing that COPD. Okay. Bullaes and blebs. Bullae. Blebs are the small little ones in the lung tissue here. Here's your little bleb right there. Some of them have obviously already bursted and caused a giant pneumothorax. Okay? But it's showing you that the size of the bleb compared to the size of the bullae. You got one on this side here. So now it kind of gives you a picture of what it's doing to that lung tissue. Right? This is the lung tissue kind of just getting compressed and put down there as well. That's what the kind of wall of the bulla is. But this doesn't do the job of the lung tissue anymore. Okay, cysts. Thin-walled. How do I tell the difference between a thin-walled bleb and a cyst? Fluid. I have air fluid levels. Cysts have fluid in them. How do I know it's air fluid levels? Well, again, gravity, I'm standing up, right? I got this nice little flat area, almost kind of like a mini meniscus sign, like the pleural effusions, because there's fluid in there. But I can trace my thin-walled area, got one here too, and then I see fluid that looks like a glass of water that I filled up, and I just got this fluid level line right there. That's how I can tell the difference from a cyst from a bleb, because they're both thin-walled, right? You're going to have some radiolucencies and lack of lung markings again, because I have this enlarged open kind of lesion area that's not letting the lung markings get in there, and now I have fluid. Okay? So it tells you, oh, it's usually thicker than a bulla. A thin wall is, less than 3 millimeters, but, usually thicker than 1. That's what that one slide was kind of telling you. Bulla, no fluid, cyst fluid. Simple man, simple results. Right? And then I'll get the question like, what if the cyst has just started and there hasn't been any fluid yet? And you're calling it a bulla. I don't know what to tell you. Because you're right, when cysts first form, it's not always fluid at the very beginning. That takes time to build up, but then you can't call it a cyst because there's no fluid. I'm not going to turn around and be like, well, you measured it's 2 millimeters, and that's how you know. I don't care. Fluid or no fluid, guys? Is that a cyst or a bulla? Tricking you. Right? It is a cyst, and if you were to scroll down in more images, you would see some fluid in there. I'm not going to, if I give you this, guess what it is on the test? Oh, no. If I give you this, I won't, I'll do an x-ray, I won't do a CT for these things. With what I told you, fluid, no fluid, you could not possibly call it a cyst because there's no fluid. Right? I'm not going to do that. If I give you anything, it'll be via x-ray and have you pull it out. Because in order to truly look at this and determine the two, you need to be able to scroll through the picture and see the full abnormality, cyst, bulla, whatever, in order to make that call on a CT. Right? So I show you this to go, don't stop at just that picture, scroll through the whole thing. But if I give it to you on the exam, it will be on an x-ray. So you can pick out whether or not there's air fluid levels. Cavities. So how do I tell the difference from a cavity and a cyst? The same way I tell the difference between a cavity and a bulla, because not all cavities are going to have air fluid levels a lot of the time. But look at the thickness of the walls of the cavity. It is much thicker than any of the thin lines we have seen yet. Okay? There's some kind of immunological process going on that is causing the body to wall off the abnormality, usually tuberculosis. It could have fluid in it. It could be a pyogenic abscess. It could be multiple things, but they're all going to have these very thick walls, either on CT or on X-ray. And you can see how much thicker and inflamed and angry the walls are compared to the other 3 things we looked at. And TB patients. Yes?
We know TB typically likes the ABCs and ones. Do the other 2 have a preferred spot?
Not necessarily. It just depends on where it's at. And TB likes the upper lobe, right? And I just want to make sure, right? Because you're right. A lot of times it is in the apices. But we looked at one like cavitary pneumonia from the TB. It wasn't quite apice, but it was there. So it does like the upper lobe. But no, these other things don't necessarily have a preference, because like carcinoma can go anywhere, right? It goes anywhere. And same thing with the pyogenic abscess, it can happen just about anywhere. So then what I would say is if you're trying to diagnose this patient, when you get to diagnosis and not just image recognition, where is it at? Is it in a different lobe than the upper lobe? Maybe now I'm leaning down towards my carcinoma or pyogenic abscess differential for the cavity as opposed to tuberculosis. But more importantly for that, I would use patient history and travel history. If they haven't left the greater San Antonio metropolitan area their entire 37 years of living, or recently brought in a family from a third world country where tuberculosis is rampant, probably not tuberculosis. You get a lot from your history. That's it on those things. Right? So look at the differences between blebs and bullae. Understand how to tell those things apart. Understand how to tell apart bullae and cysts, because they have some similarities but have just a little bit of difference, and then know that cavities have the thicker wall. Okay. Bronchiectasis. What is that? Localized irreversible dilatation, here we go, kind of people say it, as part of the bronchial tree. A lot of words on this slide, okay? I draw your attention to the symptoms and the potential causes, okay? Recurring infections, rheumatological diseases, but primarily we are talking about a productive cough, copious amounts of sputum. Half a liter a day? That's disgusting, yes. And it's nasty and it's foul smelling. It just smells like just rotting sputum. I don't know what else to describe it. It is nasty. And the patient's going to tell you. They'll be like, hey, like I've been sick before, but like I'm coughing this stuff up and like it reeks. And then when you ask them how much, you're gonna be like, a lot. You're like, well, what's a lot? And so 200 to 500 milliliters a day. That's up to a half a liter. And they may cough some up right there for you. What they'll do sometimes, no joke, had it happen multiple times. Yeah, I brought you some. And it's like filled. And I'm like, when is this from? They're like, oh, this was just from this morning before I came in. And the appointment's at like 10 a.m. And I'm like, oh, like you should smell it. No, I'm not smelling it. Like, don't say stuff like that. They'll bring it in sometimes. Anyways, copious amounts of sputum. Probably going to have some hemoptysis as well, okay? All the other things, right? Halitosis makes sense, but all the other symptoms are the same as everything else we talked about, except for the copious amounts of sputum, right? Chest x-ray is your initial study. Often normal. Often normal, even in advanced disease. You might see some of these abnormalities with tran-tract, cystic lesion, often normal. CT is your study of choice. Now we finally gotten to one where I'm like, yeah, you're going to do the chest x-ray, but that's not going to be good enough to diagnose this dang thing. You're probably going to need a CT. That's your study of choice to find this. Because what you're going to see is the thickened airways filled with mucus, and you're going to get something called a signet ring sign. Okay? And honeycombing. The base of the lungs, look how thick, look at all the mucus here, look at all the mucus here, okay? And then I got the posterior part of my lungs, not really the base, but the posterior part, it looks like a honeycomb, it looks like a beehive, all this honeycombing. This is from all the mucus in the airways. It's making all of those bronchioles kind of stand out because of how much mucus and thick inflammation there is sitting in there. It looks like a honeycombing pattern, all right? The signet ring sign is right here. You'll see another picture of it. It looks like a ring with a little pearl on it. Why does it look like that? Well, because what runs with the bronchioles? Vasculature, right? So what you're seeing is a thickened mucus and thickened wall of the bronchiole with the vasculature right next to it on top of it. But it's all inflamed. Everything's inflamed and angry because of this infection. Okay? Here's some more pictures of it. The red arrows are your bronchioles. The white arrows are your pulmonary arteries, your vasculature, giving you that nice little ring with a pearl on it. That signet ring sign. So, yes, kind of like the cuffing, right? But the difference is the parabronchial cuffing I'm not seeing those those pulmonary arteries on that. Because that's just fluid. That's just fluid around. There's not an infection, there's not inflammation, there's not other anger, that kind of stuff going on. So that's where the ring sign comes in, and the honeycomb, and the copious amounts of sputum. Right? Here in advanced areas, this is a really, I told you most of the time on x-ray you're not going to see it. Oh, yes, sir, sorry. Thank you.
Is this treatable? Is this kind of irreversible wastage?
So no, it is treatable. We need to treat the infection that's causing it, and depending what's going on. So if I go back, it's a chronic inflammatory or infectious process.
It's from like cystic fibrosis or...
Yeah, so that's, I don't know, that's less common cause. So I think, and I don't know this for sure because I'm not a like neurological genetic expert in this aspect. I would be referring cystic fibrosis out. But my understanding from what I do know is that you can't, because you can't necessarily treat the cystic fibrosis really well, this ebbs and flows. So you end up having it for a little while, we gotta try to treat the symptoms, help you get better, and it could happen again if you're a patient with a rheumatological disease or cystic fibrosis. The goal is to try to treat the appropriate causation of the bronchiectasis if it's not recurrent infection, right? If it's one of these other diseases, to limit the episodes that the patient is going to have. But when it comes on for those guys, we just need to treat the symptoms until they can get better. Here's what it looks like on that. Oh, yeah.
Slide up. Is there no honeycomb in that just because what you were looking
Yeah,
at?
it's
just not.
it's one of two things. It's either not severe enough yet to show the honeycombing, or it's just the slice that I'm giving you to really make those signet ring signs stand out. Either one is good enough with the symptoms that we have on the symptomology slide, right? Either one of the signet ring signs or the honeycombing is enough to diagnose with the patient presentation of bronchiectasis. I don't need both. One or the other is okay. So this is showing you some of the x-ray findings that were on that slide. Really hard to see, even from when you get to an advanced level of seeing this stuff, right? They're trying to say, like, oh, here's the tram tracking. Great, it's because they put yellow lines there, right? It's so hard to see on x-ray. They tried to circle a signet ring sign, which is right here. Okay, thanks, right? I don't see that either. This is more to drive home the fact of, if you suspect bronchiectasis, get that CT. That's what's going to help you diagnose it. What is that? I heard blood. Cavitation? Yep, it's a cavity. Look how thick those walls are. Look how thick those walls are. Not going to make tell you what causes it, right? This particular one was a non-tuberculosis mycobacterium, right? But know that it's a cavity. What do we got here? Which means it's what? I want to hear y'all say it. I want to hear y'all say bronchiectasis. Correct. Right? So I got my honeycombing happening right here. Do I see a ring sign? Maybe right here. If I were to call it, maybe. I would want another slice and kind of make it better, but here's my pulmonary artery. Right? And then maybe right there. What do we got here? Cyst, yes. What else does this look like that we talked about yesterday? That large cell, right? It kind of looks like the large cell. But I got an air fluid level. So I'm going to call it a cyst. What's up? Right here. Oh, air fluid level. Yeah. Right there. I know, I got to get them to fix this podium so I can actually draw on it. Good. Let's talk about the mediastinum a little bit more. Okay, so when we talk about the mediastinum, all we're doing is knowing where the anterior, middle, and posterior sections are, and what the most common types of masses will likely be there. Okay? This is the definition. I'm not going to read this, we're going to go to a slide. I'm going to show you lines and highlighted areas like we do the lobes. This is the definition of my anterior, my middle, my posterior mediastinum, where they start and where they end. Okay? Here's where I want you to hang your hat. Yes, CT scans, right, of the chest are more accurate in dividing up the mediastinal area. It's fine. What kind of questions might you see on this one? Not necessarily pictures, but what's most common in areas, right? If I have what looks like abnormal masses in any of these things, guys, memorize middle and posterior, and if I ask you a question about it, and it's not that or that, well then it's gotta be that. Simple man, right? Simple way to study things. You will eventually learn about the thymus gland, the teratomas, lymphomas, the thyroid, and all those masses. We're going to look at some of the pictures of what they look like. Okay? We're going to look at some of those. So I could ask you a word question like this, or I can give you an x-ray with saying the anterior ones, like where is it at, like that kind of thing. What is this? The thyroid's going to be always up here. The thymoma is going to be in the center of the chest. We're going to see some of that stuff. So, but as far as trying to remember what's where, well, only got one of those categories right now. How do I differentiate from a mediastinal mass from a parenchymal mass on lung x-ray? So this helps you break it down because there is some overlap, right? So if the mass is completely surrounded by lung tissue in both the PA or frontal view and the lateral, i.e. I can see the mass and I can see lung tissue around it on both of my images, that is not in the mediastinum, it's in the lung. Because I have clear lung tissue all the way around it. It's not in the mediastinum. That is a lung mass. That is a parenchymal mass. That is a cyst or a cavity or a cancer that we talked about, right? Because it has all of that on both images. If the margin of a mediastinal mass is sharper than the mass originating in the lung, that's in general, you're going to see that. A sharper margin because the mediastinum ends and the lung kind of filters out with the vasculature, right? And it kind of goes out to the peripheral. Also, mediastinal masses will displace, compress, obstruct other structures. Trachea, esophagus, because it puts pressure on it. Really, the biggest one is that first one. If both images are showing you lung tissue completely around the masses, it's probably a lung mass and not a mediastinal mass. But ultimately, if you think you have one, you're getting a CT. Because you need that detail. What is it attached to? Where is it at? I have a suspicion, but I'm going to get a CT to verify it. Thyroid mass right there. You guys see it? Thyroid mass. See it? What are my hints, though, that there's something there? Look at the tracheal shift. Something's pushing it. How do I know it's pushing it? I don't really see massive atelectasis pulling it, right? Something's pushing it. So this is going to be a thyroid goiter that has gotten really big. It's coming down. It's not in the lungs, but it's enough to be pushing those other structures like the trachea or the esophagus over. So what do I do if I suspect thyroid? So if I suspect mass, right, and I don't know what it is, a CT is a study of choice to confirm where that mass is. But the question specifically tells you that we suspect a thyroid mass. I don't need a CT anymore because I've already told you what the mass is. How do I further evaluate that? The radioisotope thyroid scan or that thyroid scintigraphy that we had on the last block, right? That's how we evaluate that because now we know what mass it is. So where are we at? What information do you have? What am I asking? Study of choice to evaluate the mass that I haven't told you what it is. It's probably going to be a CT to narrow that down. But once we know what it is, now how do we evaluate that area? For the thyroid specifically, it's that isotope scan or scintigraphy. This is kind of what it looks like on CT. T stands for trachea, not thyroid. air, okay? But what we end up seeing is we see this giant goiter on the CT scan, and when you scroll up and down, you'll be able to see that it's coming off of the thyroid, just right up here in the neck area. A lot of calcifications a lot of the times. Okay, with that mottled appearance with IV contrast. So this is before contrast. All right, so these are calcifications. How do I know it's before contrast? Look at my heart and look at my aorta. It's all gray. That's not contrast in the goiter. Those are calcifications. But then when I give the contrast, look at how mottled it gets. Look at all of this blood flow this thing has. Right? Now it gets even more mottled. Those are my goiters. Lymphoma. Whoa. Right there, guys. Yeah. That looks like about 6 other things we've talked about. All right, let me just make sure my dotted arrows. Let me get you guys on a break here in just a second. Okay. So, most common cause of mediastinal mass overall is lymphadenopathy. So, that's a nice question there. Most common cause of mediastinal mass overall. Chest X-ray will find the mass. Don't know what's going on. Do my systematic process. Don't see any major lung issues. Don't see any pneumothoraces. Don't see anything wrong with the lungs in that aspect. So I'm going to get a CT to better define it. Okay, we got our ascending aorta, descending aorta, a superior vena cava. This is just showing you what the CT looks like. And I got these extra masses sitting all over the mediastinum. All I need you to know. Where it's at, order CT. Where it's at, order CT. Where is it? It's in the anterior. Anterior mediastinum. Take 10, come back to the top of the hour. Apparently 75-cent Whataburgers today through the app, I just heard, so you guys want to go to lunch, go, and after this. That's what she was just saying, I don't know. But you gotta download the app apparently, it's probably because they don't want 800 people on the store. 75-cent Whataburgers? I don't know. Talk to people all over here. She knows all about it.
75-year anniversary.
She's like the Whataburger mascot. That's okay, is that a thing that I just saw yesterday where apparently now Disney Plus and Hulu, did you see this? They're merging their apps next year. So like Hulu will no longer be a standalone app, they're going to merge it together to make it just one, and I'm sure change their price. They're going to charge more. As I said, I'm looking forward to the day when all the apps merge together and they call it cable. Right? And right back to what it was. Alright. Someone brought something up on the break, and I appreciate it. So therefore, I almost never say this. I will not be giving you a test question on lymphoma versus lymphadenopathy because this is confusing. I did not realize this. Lymphadenopathy is a middle mediastinal mass. And here I have it on the lymphoma slide talking about it. So to be clear, from a medical knowledge standpoint, lymphadenopathy is the most common cause of mediastinal mass overall. That is a true statement. That is a true statement. Lymphadenopathy frequently presents with a border that is lobulated or polycyclic in contour. That is a true statement. What you typically have is, when you have lymphoma, guys, you have lymphadenopathy. And that's kind of what I was trying to draw together there. But I recognize when you're studying at home or whatever, that can be really confusing with the way I have it worded. So I need to fix that for next semester and move all my lymphadenopathy stuff into, when we get to it, the lymphadenopathy slide, and then kind of explain it that way. So because of that, and because these are the slides you have, I will not be giving you, let me be very clear on how I say this. I will not be giving you a question where you have to distinguish between lymphoma and lymphadenopathy. Either one of those things can still be an answer and still be a question. They just won't both be choices. Unless it is strictly, where is it at? Because that was very clear. But as far as most common cause goes, I made that confusing on here. So, sorry, I'll fix that. I'll make it better for the people after you, not that you care about those people. But, alright. Thymoma. Okay? Thymus gland in children's and invalids, do they still need that immune system? Is normal. We are supposed to have a thymus gland. The thymus gland is basically a immune system repository, which is why as you get older and you build your own immune system, the thymus gland shrinks. Okay? But you can get what's called a thymoma, which is basically a tumor or a growth on what's left of your thymus gland. They're usually benign. Okay? Myasthenia gravis sometimes is associated with it. Same as before. You're going to get a chest x-ray to initially get it. You're like, that looks like a mass. I don't know what that is. So then I get a CT to further delineate it. What do I need to order when I see this? Right? Which really goes along with all the cancers we talked about. If I'm asking you what to order to after you see the x-ray, like what's your next study or your study of choice to really further delineate it, even for all the bronchiolitic carcinomas, here was a CT, was the next step to figure out what's going on. So this kind of matches up with that. I have this mass, not really sure what it is, where it is. If I want to know how to further study it, I'm going to get a CT. Teratomas. Anybody know what a teratoma is? These are cool. These are cool, right? So they're benign. They're mostly benign. They occur earlier than in life in thymomas. 30% can be malignant, right? This is basically just an overgrowth of cells. Depending how big and how long these things go, when they remove these things, and they won't remove them, because again, they can get bigger, we can see how even if this was benign, right? It's going to start pressing on the structures and start causing some issues in the lungs and in the heart, right? So they will remove them. These things come out with hair, teeth, fingernails, like depending how far along they are. They're gross, but they're pretty cool looking if you ever get a chance to see one. So they are going to remove it. Again, the CT is going to further assess it. Also, why is it important for the CT? I want to know exactly where it's at. So when the surgeon goes in to take it out, they know exactly where they're going, what they're doing. They can use that CT for planning purposes. Those are all your anterior masses. All of them require a CT. Some of them you can kind of tell where it's at. Some of them have a further study, like the thyroid, once we know that, where we see that tracheal deviation and shift. Your middle mass is your lymphadenopathy. There it is again. Most common mass in this compartment. It's the most common mass in all compartments. And so that's why when I looked at this slide, I was like, man, that's kind of confusing. So we're just going to take that type of question out. All right, because look what can cause lymphadenopathy. We already talked about lymphoma, my small cell carcinoma, or my metastatic disease, right? Viral, bacterial, or fungal infections. The lymph nodes are your little immune system factories. So anything that's causing an infection can cause lymphadenopathy, and that's what makes it the most common mediastinal mass. Because we've all had lymphadenopathy at some point in our life, and we'll have it many other times going forward in our lives. Anytime we get sick, anytime we get like a lung infection or pneumonia or anything along those lines, we are going to get some type of lymphadenopathy. It just depends on where. Right? You get strep throat, you feel it up here, that's lymphadenopathy. It's just in your neck as opposed to in your chest. So it is very, very common. If the reason we get the CT is not because we care about the lymphadenopathy, it's because we're trying to figure out what's causing it. Why are we having a lymphadenopathy? Unless I know that it's pneumonia, right? That's why we get a chest x-ray first. I'm like, oh, got some lymphadenopathy. Oh, and there's your pneumonia, and you're feverish, and you're sick. I don't need a CT because I know what the problem is. We're going to fix the problem, and then you'll get better. Which is why chest x-ray still always comes first. Because if you can find the problem, there's no reason to irradiate more. That's it. With that knowledge. Posterior is also just one. Posterior masses. Some type of neurogenic tumors. Some type of neurogenic tumors. I can't really tell it's a posterior mass on my PA. But when I do my lateral, there it is, sitting right over the spine. Why? Because that's where the spinal cord is. That's where the nerves are. Right? Usually your schwannomas are your most common. You'll learn about schwannomas in neurology next semester. They are benign. They don't always remove them. It just kind of depends on what's going on with the patient and the symptoms. But it's going to be this nice, sharply marginated paravertebral mass sitting right over the spine in that area. Right over the spine. That's the only posterior mass we have. Here's another hint on your PA chest x-ray though. Why does it look like I have this weird rib border here on the bottom? So I have a nice top rib border, but then when I come down here, and then like this weird, like kind of like little bites out of it. Posterior masses, what was that? Because the nerves run on the bottom. Your neurovascular bundle runs along the bottom part of your rib. So when you're getting this notching the bottom part of the rib, that's when you're going to be concerned. You're going to be thinking about maybe some of those schwannomas or some neurogenic masses that are causing that to happen, because that's where your neurovascular bundle is. For the same reason, when you learn to do a chest tube, for those who have done that before, those who haven't, when you learn to do it, you're feeling for the top of the rib, and that's where you're going to insert everything, so that way you don't affect and injure the neurovascular bundle of the inferior portion of the rib. So if we know posterior mediastinal masses are neurogenic, then that's why we know they would be at the bottom part of the rib. Here's a CT showing one, and you can see how it's, you can just see where it's connected right in to the vertebrae, right into the spine area, going into the spinal canal, coming out from there. Some more pictures, right? See the masses are starting to eat away at the vertebrae. Some of these things are probably neuroblastomas, which are malignant, which are dangerous. They're definitely going to need surgery and other treatments after that. The x-ray is kind of hard to see, but you can kind of see how the vertebral body, right? I got my front part, that's fine, but then like these large kind of curved areas in the posterior section. This is the vertebral body right here. Looks like a little hourglass. But the x-ray is just going to be your first hit, because you saw this x-ray. You get a CT. What are my key takeaway points? This slide, on all of that stuff, right, is my key takeaway points. Chest x-ray identifies it. CT defines it, tells you what it is and where it's at. If you suspect the thyroid, it's the radioisothyroid scan. That in a nutshell. Questions on this slide deck or anything related to the chest? We are done with the chest after what feels like 4 months. All right? Nothing for the chest? All right, because once I go to the abdomen, we're done asking chest questions. This is your chance. No? Okay, all right, give me just a second. Nope, I closed it. You had your moments. Now it's time for the belly. Only 2 slide decks on the belly. They're longer, because there's more pictures, they're longer. But we have 2.5 class periods to get through them all. Anatomy. You should be able to look at this by the end of our admin set and be able to point out anatomy things. For example, what is this? Liver. What are these? Kidneys. What is that? What are these guys? Lungs. What is this stuff? Yes, poop. It's always good when you try to make a joke, but you're right. Nope, that's all, that's poop. Now the hard question. What is this? Ooh, what is this? Okay, so here's the fun part about CBs. So look at it carefully, If it was just a bladder or just a uterus, you would expect it to be hopefully well defined in one shape and the same density. Does this thing have the same density? It does not. So what this is this is a portion of the uterus, and this is a uterine fibroid. Uterus and a fibroid. I haven't covered it yet, but yes. So the curved arrow is the fibroid, and the little black arrow is going to be the uterus that it's coming off of. Starting to necrose a little bit, that's the changes in the colors. We give some contrast, that's a reason for it too, but it looks not normal. Okay? It's not this well-defined thing. We'll take a look at some of this stuff. All right, so we're going to cover an intro, GI imaging and GU imaging. This is what we have left. Whew. Vocabulary. Vocabulary is going to be important in this so you understand what we're looking at. Specifically, the haustra and the vabulae combinantes. The haustra and the vabulae combinantes. You need to know which one is which. Haustra gives what its segmented appearance? The colon, otherwise known as what in layman's terms, basic anatomy terms? Large intestine. Vabulae combinantes focuses on the duodenum, or the small intestine. You are going to see how that's important as far as distinguishing when we're looking at an x-ray. You are going to be able to tell the difference between small intestine and large intestine, which we break it down and look at it based off the haustra versus the vabulae combinantes. We'll talk about interlumen, extralumen air, diverticula, we'll look at, we'll see what that looks like. The sessile and the pedunculated stuff is going to be more for you interpreting your reports, right? Explaining to you what's going on. So pedunculated is on a stalk of tissue. A sessile lesion is just sitting there, immobile, fixed, placed, that kind of thing. And we're going to look at more phlebolates, fecalates, and appendiculate. Lith is stones, right? But phlebe is in the veins, feco in the colon area or the rectal area, right? And then appendi in the appendix. So we'll take a look at all of those things of calcifications within those structures. Introduction. Why do we do x-rays on the abdomen? All these things. Are we going to be able to diagnose all those things with just the x-ray? Not all the time, right? Not all the time. We are evaluating abdominal pain, okay, and trauma for the pelvis, right? We're evaluating for any type of, oh, I feel bloated, abdominal distension, I think I have kidney stones, gallstones. Am I going to see those all the time? No, I'm not. But much like the chest x-ray, if I don't order the abdominal x-ray, I might miss something else. I might miss the main cause. Because all these other studies are very specific, looking for a certain thing. The ultrasound for the gallstones is just looking at the gallbladder and the gallstones, right? When we talk about it, the CT for kidney stones, or the ultrasound is just looking for the kidney stones with the way they do the technique, right? Because you can't give contrast with that. We'll talk about that later. The x-ray looks at everything to make sure you don't miss the generalized look, which is why it is often and almost always the initial study, but not often the definitive or study of choice. Because very rarely is that all we're going to need for a lot of the other conditions. Why we do CT, trauma, virtual colonoscopy, abdominal pain, vascular concerns. Okay? What else can we see on CT? Rupture perforation, colon diseases, colitis, diverticulitis, we're going to talk about those. Colon cancers, appendicitis. Sometimes we'll do ultrasound, sometimes we'll do CT for an appendix. We will talk about who we do that and when. Very similar to the mammo thing, right? We got a cutoff of breast pain of when do we do ultrasound versus when do we give radiation. We're going to do the same thing for the appendix. Okay? Urinolithiasis. Ureter stones or kidney stones, nephrolithiasis, same concept, without contrast. Almost everything we've talked about with the abdomen has been with contrast. I want to be able to see the organs. I want to be able to see the blood flow. I want to see the vessels. I want to see everything. Right? I don't want to scan it once and I want to see it all. There's a couple of times we do it without, and we'll talk about that, which is going to be the kidney or the ureter stones. We'll talk about why that is. Very similar to the CT head without contrast. Okay. Remember contrast versus the IV contrast. What am I trying to find? What am I looking at? There's two different kinds, okay? We're not going to give the barium if we're concerned about a perforation, so it's not water soluble. All right. If you go into the book, the table 14.1 and 14.3, if you're doing that, it's FYI only, but for people who want to kind of get a little bit deeper, I'm not going to pull questions out of that table specifically if it's not already in the slides or something else. Remember these slides? You're seeing them again. So click, click, right? We already covered it. Click. Covered it last block. It's important to still know for this block. I have them in there for you, not to go over them again, but for ease of access, since you're studying block 2. Okay? All the same stuff we talked about of when not to give contrast. Know that. That's important. So what other imaging do? We do ultrasound on the abdomen. Why do we do ultrasound on the abdomen? Well, we could do it for trauma in the setting of that EFAS like we talked about. Any reproductive organ masses or pain. If it's a part of the reproductive tract, testicles, ovaries, uterus. You can't really see fallopian tubes on ultrasound. We'll talk about that study specifically. But any reproductive organ mass or pain, we're doing an ultrasound because I don't want to irradiate the reproductive organs if I don't have to. Abdominal aorta, vascular concerns. So I know we looked at it from the CT, but that screening, sometimes we can do that abdominal aorta and take a look and see how big it is. Right lower quadrant pain in peds and gravid patients. What is gravid? Pregnant. There it is right there. So if I'm trying to evaluate the appendix for a pediatric or a pregnant woman, I'm doing an ultrasound. If it's me, y'all are ordering a CT. Because I am not a pediatric nor gravid, at least as far as I know. Nor gravid. Right upper quadrant pain. Gallbladder, ultrasound. Gallbladder, ultrasound. Biliary tree, HIDA scan. Right? It'll help us see free fluid. We can use it for vascular flow and vessel diameter, which we looked at as far as the Doppler versus the duplex, that kind of thing. We already talked about the reproductive organs, blood flow, masses, thickness. Pregnancy, OB assessment. Not to find out if it's a boy or a girl. Okay? The 20-week ultrasound is not meant to figure out what, it's meant to make sure the baby's the appropriate size, growing appropriately, has all the parts that they need as far as the bones and structure, and sure, if we can find it, then they'll tell it to them. But everybody has this misconception. I'm like 20 weeks, is it figure out what's a boy or a girl? No, it's not. Plus, I think a lot of times now we just do a blood test at like 8 to 10 weeks and find out already. So, science. Appendicitis in these types of patients. Cholecystitis or gallstones, which we just talked about there. Hydronephrosis, often secondary to kidney stones or nephrolithiasis, can be the initial study for recurrent stones. We just got to say that we'll look at a CT for kidney stones, but if it's recurrent, we might do an ultrasound. We'll talk about it when we get to that stage of what is that cutoff and when do I do an ultrasound versus a CT and why. A little bit of a fuzzy area there, but we'll try to clear it up. All right, what else can we do? We can do an ERCP. Endoscopic retrograde cholangiopancreatography. Everybody together now, 5 times now, right? What is this? So this uses both endoscopy, so you can see the endoscope, and uses fluoroscopy, so that live x-ray, it's a procedure, to go in and pull out any potential obstructions within the biliary tree or pancreatic ducts. So think of it this way. Did the HIDA scan, found an abnormality, it didn't push it through. Now I do ERCP, so they can go in, and inside here, you can't really see it, but inside here is like the little like Toy Story claw, and it comes out, and it'll grab the stone, and it'll pull it right out. So the nice part about the ERCP is because they can also pump contrast in here too if they want to kind of highlight it out and see where the blockage is. Let's say you don't have nuclear medicine. You can't get a HIDA scan. You can do just this. It's both diagnostic and therapeutic because once they find it, they can pull it out, fix the problem, move on with life. Anatomy. It doesn't look this pretty inside of your bodies. Well, maybe some of us, not mine. In reality, the intestines are all over the place. And I say that because you start looking at the x-rays and you're like, well, why is there just like that? That's the general shape, right? They move and they're all over the place depending what's going on. So, but these are all the things that are in the abdomen. These are all the things we're going to look at and try to evaluate. This is a wonderful picture. This really breaks down the anatomy on a CT scan. It's not labeled, but what's that? What's that? That's the aorta. It's not the esophagus. You guys love the esophagus, like as students. Love the esophagus for some reason. But that's not the esophagus, that's an aorta. But this really breaks down, this is a nice cross-section of the main part of the abdomen, really breaks down all the organs. How come I can see the left kidney? Where's my right kidney? Lower, right? I know my anatomy means the right kidney is supposed to be lower, so I'm not concerned about that yet. Especially since I have such a large portion of the liver still on the image, I'm not overly concerned. I'll be able to keep scrolling in real time, in real life, and be able to see both those kidneys. Okay. Stomach has that air fluid level. You notice how it's the only one on a normal CT scan that has the air fluid level. None of the other organs have air fluid levels. Cool. What type of slice is this? Coronal. You guys remember stuff. Both kidneys. Gallbladder hidden in my liver. Gallbladder. Darker area hidden in the liver. Okay? Spleen. Small portion of spleen. All these little lines and kind of grayish areas right here, this is basically your mesenteric artery system going out and feeding your intestines. These are the guys who are concerned about those kids that swallowed magnets, kind of blocking off those mesenteric arteries. Not good, you end up with necrotic bowel. Large bowel, small bowel. Large bowel, small bowel. And you guys look at it and go, well, that's easy, one's bigger than the other. And it's not like that on x-rays all the time. Sometimes the small bowel will be larger than the large bowel because of the abnormality. But we'll look at it, and you guys will get it down. Bladder. Yay, bladder. Okay. There we go. Let's jump into these guys. And look, finally, I'm going to show you the esophagus. Esophagus, stomach, bowel obstruction, and ileus. These are the things we're going to go over. We're going to go over some abnormalities, but we're also going to go over imaging, because everything's just a little bit different depending on what you're looking for. And this is really what we're going to get out of this for the most part, is what imaging do I need to do, or what main abnormalities might I see when I order that imaging. So the four main areas of evaluating the abdomen, you're looking at the imaging, primarily the x-rays. You're looking for the overall gas pattern in the bowel. We have gas, that is natural, that is normal. Some of you have seen it on some of the x-rays already, you pointed it out, like on those pelvic x-rays, hey, what is that? We're like, hey, that's bowel gas. And so we're going to look at what normal should look like, because when you understand where it's supposed to be, when it's not there, it can lead you towards thinking other things that might be going on, okay? We'll look at free air. The air should be within the bowel and the stomach. That's where it should be. It should be nowhere else. If it's out and it's free and it's floating around in the abdomen, that's a problem. That means we have a perforation somewhere. We're going to kind of know how to look at that when we get to those slides. Soft tissue masses or organomegaly. We're going to look for large organs and see what that looks like. And then any abnormal calcifications always makes us concerned for abnormal growths, whether it's a teratoma or some type of tumor or cancer. I can talk about where air normally is. So when you order an abdomen x-ray, usually what you end up getting is what's called an acute abdominal series. It's a supine abdomen, so they're lying flat. They take a picture of the belly. Then they stand them up, and they take a picture of the belly. And then they do a chest x-ray with it. Why do they do that? It's kind of like the MSK with the joint above and below, right? I want to make sure I get all of the abdomen, right? And sometimes maybe that diaphragm might be cut off a little bit. I want to be able to see above the diaphragm as well, because there's something which we'll look at, I think at one point very shortly, something called a hiatal hernia. to where the stomach can go up through the diaphragm and sit in the chest. Well, if I just do the abdomen, I might not catch all of that. So that's why it's a flat abdomen, an upright abdomen, and then a chest x-ray is usually the 3 pictures you're going to get whenever you order that abdominal series to fully evaluate everything. And then, yeah, so other imaging to replace regular x-rays when we need it. Okay. We're going to cover normal studies as always, the acute abdominal series, calcifications, organomegaly, computed tomography. You guys know the routine by now. Okay. So where do we have air normally? Stomach is normal. Can't really see the stomach on this one. So you can see kind of why we get those other images, right? So here's my supine one, okay? Small intestine, not a whole lot of air in the small intestine. Why? Because there's lots of gastric juices. There's lots of fluid in there. That's where most of your digestion is happening. So there's not usually tons of air in the small intestine. Sometimes there's a little bit, but not usually a lot because of all the fluid that's in there, all the digestion that's happening. By the time you get to the large intestine, the digestion is done. The large intestine's job is to reabsorb all the extra water and fluid that you still need for your body from the stool and make the stool more dry, a little bit harder and compacted together. And so when you do that, you naturally are going to create a little bit more air. And that's why most of your air is going to be in your rectosigmoid colon, which is the very end, the terminal end of your large intestine. But you can absolutely have some in the transverse, the ascending, descending, that kind of thing. You can even have some in the small bowel, but not very much usually, okay? The prone x-ray is meant to show you, right? We almost never order prone x-rays on the abdomen, but I found one to show you. This is the same patient. Look at how the bowel gas pattern changes when I flip them over and air moves and kind of rises up to the back area. Okay? I'm not going to give you a prone x-ray, but I'm going to show you how you can use the movement of the air pattern to figure out if something is normal or not when we're looking at it. Okay? So when I'm looking at an abdominal film, the first thing I do is I look at my overall gas pattern. We'll see enough of that for you guys to start to see kind of what the normal is. That's the first thing I'm going to look for. Then I'm going to look for any extraluminal air. So what is that? Air outside of the bowel. We'll see what those abnormalities are when we get there. Third, I'll look for any calcifications. And then fourth, I'll look for soft tissue masses. Now, how do I see soft tissue masses on an x-ray? Right? And they're hard to see, right? Recognize that they're hard to see. So what we're going to do is I'm going to show you what happens to the bowel gas pattern when there is something there that's not supposed to be there. Right? When I have a large liver or a large spleen or I have a mass on those, now I have something in the body that's not supposed to be there. So it's going to naturally affect other organs and other things that are within the abdomen. And that's one of the ways we'll be able to tell if there's a soft tissue mass or a large organ or not. What are these white dotted arrows? Anybody know? It's a psoas. This is a really thin patient, so you're able to see those psoas muscles. So that could be an abnormality if we didn't know our anatomy and our muscles and kind of know that, hey, that should be normal. You won't see that on most abdominal x-rays, especially in America. You just won't. Sorry. We make fun of ourselves, it's true. Heart disease, not good. All right. Okay. So again, this is kind of covering where the air bowel gas pattern should be. All bowel is distended, not dilated. Dilated bowel is a problem. Dilated is much more. Distended means there's air in it and it's causing some distension. So that is normal to see. You're always going to have air in the stomach up here. This is where your gastric bubble is going to be. That is normal. Small intestine, small amounts of air, and you'll start to see what the small intestine, large intestine looks like, okay? Also, though, if there's air in the small intestine, we will commonly see air fluid levels, primarily on the supine or the upright abdomen? The upright. Because if I'm supine, that fluid lays out. I'm not going to see air fluid levels on my supine. But when I do my upright, if I see some air fluid levels, that air is going to be in your small intestine. Because there's a lot of fluid in the small intestine. There's not a lot of fluid in the large intestine, so most of the time, if I don't see air fluid levels on my upright, then it's going to be large intestine bowel gas. Don't worry about the sizes for the test, right? It tells you when we hit dilation as opposed to distension. If I give you one that's dilated, it's going to be dilated. Like, it's going to stand out. Large bowel is generally peripherally located, except in the right upper quadrant. Why? Liver. Liver's pushing it out of the way a little bit, so it's not going to be nice and peripheral here. Your right, my left. Nice and peripheral in this area, okay? But it will be peripheral in most of the other areas. The haustral markings versus the small bowel markings, okay? Your haustra on your large intestine are not going to connect because it's a large intestine. So you'll see these little kind of radio-opaque lines, but you won't be able to draw the lines together, right? Your mind's eye will, but you won't see it on x-ray. Your small bowel, when we get to the valvular condimentes, those lines come all the way across because it's smaller, so we'll see those kind of circles and those loops on there. Okay? So here's an example. Small intestine, large intestine. You come over here and do it. So these little loops here, see how it almost looks like it connects, but it doesn't. These little guys here, the line comes all the way across. These ones here, they don't. They stop kind of halfway through. Comes down and stops, comes down and stops. Okay? This is with the contrast. This is without. So yes, you can get an X-ray contrast. It's a barium enema, is what they call this. Here's where they put in the enema, blew up the balloon. That's not an abnormality. That is the balloon of the enema tip to keep all the stuff inside that we want to stay inside. Right? And then they push the barium up, and it's going all through the large intestine, coming down, and now it's starting to spill out into the small intestine. Okay, these are two different patients. Just kind of showing you the difference here. But look at my large intestine on that contrast one. It is not this pretty little thing like they show us in all the anatomy books, right? It is moved all over the place. Okay? Your white arrows, those are some diverticula. We'll look at that more a little bit later. Outpouching of the intestine, that's what those are showing you, some diverticula. This is showing you your hepatic flexure, your splenic flexure, your transverse colon. Okay? Blue arrow here, hepatic flexure, splenic flexure, transverse colon, diverticuli. Similar areas here. How do I know this is upright? It tells me it's upright. And it should be like that on all your films, right? Because if there's not air fluid levels, how do you know if it's upright or not? You can have no air fluid levels on an upright x-ray. So because supine abdomens are the standard, whenever they do an upright, it will tell you on the film upright, or on the test I will tell you, you got an upright abdominal x-ray, or below is an upright abdominal x-ray. Even if it doesn't say it, I tell you it, I want you to, it's an upright. You cannot just look at it and be like, is that upright, is it not? Sure, if there's air fluid levels, you can make that conclusion, but not all of your uprights are going to have air fluid levels. Right? So, but when you do the upright, you should have that nice air fluid level and gaseous level in the stomach. Okay? Your small intestine has small little air fluid levels in here. Small little air fluid levels. Small little air fluid levels in your small intestine. That's how I know it's small on this one. My large intestine area, I have no air fluid levels. That's how I know this is large intestine. Is that a 100% solution? No, but it will be for this test. Okay. It'll help break down exactly kind of what you're looking at and which intestine it is. Here's a chart. Don't worry about prone. I'm not going to give you a prone x-ray. It is almost never ordered. So I'm not, it's there just in case somebody decides to want to ask you how best to ask the rectosigmoid colon. It's not going to be me. All right. We will do prone CT for something, but not an X-ray. Okay, we'll talk about that when it comes time. So this one here is just showing you supine abdomen. What am I looking for? Overall bowel gas pattern, calcifications, and masses. If I do the upright, I'm looking for those air fluid levels or that free air, which is really what the chest is for as well, is the free air, pneumonias, pleural effusions, that kind of thing. The free air is what the main reason is for that upright, and the air fluid levels. And we'll see where that free air goes when we get to those slides. And this, it works for those who are traumatized by charts from previous classes. I'm not going to say what those classes are. If you like words, here are words. All right, let's talk about a couple of calcifications. Flea lifts, we've seen these before. Don't need to spend a ton of time on them. Small rounded calcifications, they're venous thrombi, they sit in the veins, right? Most often in the pelvic veins of women, primarily as they get older. Can they be in other areas? Sure they can. But realistically, most commonly in women of older age. That's all you need to know about flea lifts. Just know that they're normal and who they can be in. So it doesn't trick you to thinking that there's an abnormality. These are not a bunch of kidney stones that fell into the bladder. These would be massive if they were. I feel bad for that person. They never would have made it this far, actually. They're way too big. They never would have made it through the ureters. But those are normal. Rib cartilage. Oh, we talk about we can't see rib cartilage on X-ray? We cannot. Until you get older and they start to calcify. So that is the calcification of the rib cartilages. Cartilage, I gotta get really better at plural words. Right? How do I know it's a rib cartilage? Well, it follows the arc of the way the rib cartilage is shaped. Right? It follows that shape. It's got this weird kind of speckled amorphous appearance, which can get tricky because we talk about amorphous calcifications as potential malignancies. Right? We get concerned about that. That's more if it's like within a structure, within a tumor, within an organ. But if we can trace it down the ribs and the rib cartilage, this is a normal calcification. Now, abnormal calcifications, rim-like, linear tract-like, lamellar, and cloud-like amorphous, like I just said. But again, the reason that this can be normal is because it's within the ribs. It is the rib cartilage. Talk about some abnormal calcifications in the abdomen that we should not have. Like this guy. It's a porcelain gallbladder. Okay? So rim-like, basically they're going to be cysts. Renal cysts, splenic cysts, cysts that are calcified within an organ. That should not be there. Organs should not have calcifications in them. That is a concern. The aortic aneurysm, or splenic artery, renal artery aneurysms, we saw some of those in some of the other pictures, how sometimes the wall of the aorta starts to calcify a little bit. That happens in the aneurysms as well. That is a sign of an aneurysm if you don't notice the size of the vessel. If you see that aortic wall calcification, they probably have some kind of aneurysm going on there. And then the bladder or the gallbladder, if it calcifies, that's an issue. This is probably a patient who has chronic cholecystitis. Kept happening. Your body's like, I'm done. I'm going to take away your nerve endings. I'm going to take it away. I'm just going to calcify it so it doesn't hurt anymore. Well, once it does that, guess what it's not doing anymore either? It's not squeezing bile anymore because it's calcified. So they will likely surgerize and remove that guy. Because you don't really need the gallbladder anyways. You don't. It's nice to have, but you don't need it. So here's your linear or tract-like. I want to be very clear because this was pointed out before. This is not the femoral artery. I know it looks like, hey, look, the femoral artery, all right? No. What is this? That's the femur. This is an amputation. The black arrows are the femoral artery coming down, with the calcification. RADS Block, when we were looking at all of these x-rays for the femur and the lower extremity, did we ever see any of the vessels? We did not, because you shouldn't be able to. And whenever you see the vessel like this, it's the artery. Veins don't calcify. Don't ask me why. I don't know. They just don't. So it is the artery that has calcified. So that's what these are, the linear or tract-like calcifications. It can happen on any of your tubular structures. They can happen in your uterus, your fallopian tubes, your vas deferens. I've never seen that before, but it can happen. I typically see it in my actual vasculature. There's the staples to show you that. And we did it. If this part wasn't clear. There's no femur. Well, it's there, it's just gone. So yeah, so it's not this. This is not the moral artery. Here's your lamellar calcifications, right? A bunch of little stones kind of stuck together. That's what it looks like. So most commonly in the gallbladder, the regular bladder, the kidney, right? When we get a bunch of them and they're lumped together like this, those are your lamellar ones. Those are abnormal. We're going to want to get rid of those, especially this many. Now, if I have just like the two in the gallbladder and it's an incidental finding like right here, because that is the gallbladder here, and those are two little stones. If the patient is asymptomatic and they're not having any issues, they've never had any inflamed gallbladder, cholecystitis, any of that stuff, we're going to leave it alone. Just not cause them problems. They can walk around and live like this for however long they need to until they start having issues. We're just going to leave it alone. Now, if it was like this, probably going to take that out because if they're not having symptoms, they're going to eventually. That's a lot. But the onesies, twosies, couplers, if they're not having any symptoms, we leave it alone, but they are still considered abnormal calcifications because they're not a part of the body. It's not like the rib cartilage is calcifying, that's a part of the body, right? These are extra lamellar calcifications. And then finally the scary stuff. What's the difference between this amorphous and the rib cartilage amorphous? These are in organs. This isn't a cartilage, right? I got calcifications within the body of the pancreas, within the uterus, within the lymph nodes, within the kidneys, right? These are within organs. These are not there's no cartilage in these guys. So it's not normal for them to calcify for any reason. Notice how it's fuzzy, right? You can't make out the edge. I mean, I can make out it's a pancreas by looking at the shape, but I can't make out the edges of the calcifications. Right, it's got that popcorn little appearance. If you get a bowl of popcorn, you look at it, you got all these kind of little, all just kind of sitting in that bowl of popcorn. This is bad news. So I know it just says it's chronic calcific pancreatitis, but if it's not already, this is probably going to end up leading to a pancreatic cancer. Chronic pancreatitis in general usually leads to a pancreatic cancer. Don't freak out on the next chart. It's FYI, you do not need to know all of these things. But what this can help you do is it can help you understand which organs might be in which quadrant when we're trying to figure out symptoms or looking at images and things along those lines. Okay, I'm not pulling questions off of this, but this will be beneficial to you in the future. And you'll still believe it, you won't use it, but I can say it. I remember doing it. And I'm not going to start a new topic. Okay. Questions on that? That was very generalized from the abdomen.